Welcome to today's webinar on what's teeth got to do with it, the oral and dental side effects of cancer therapy. My name is Monica Bryant and I'm the Chief Operating Officer of Triage Cancer. Before we get started, I need to just go over a little bit of housekeeping. All callers will be muted for the duration of the webinar, and if you have any questions or technical problems throughout the webinar, please type them in the chat box to the side of your screen. This webinar is being recorded and will be available for viewing on our website, triagecancer.org. At the end of the webinar, you'll be redirected to a survey, and please take a few moments to fill it out and let us know what you think about today's webinar. We really do take your thoughts and comments to heart. Triage Cancer is a national nonprofit organization that provides education and resources on the entire continuum of cancer survivorship issues to survivors, caregivers, advocates, and healthcare professionals. And we do this in a couple of different ways. We host a speakers bureau of experts and survivors available to anyone hosting an educational event, and a speaker request form can be found on our website, again, triagecancer.org. We also host an educational blog, provide online resources, and participate in seminars, webinars, and conferences all over the country. More information about all of these services can be found on our website. We would not be able to provide webinars like this one without the support of our webinar sponsor, Fifth Season Financial. Fifth Season Financial provides loans to people living with advanced cancer secured solely by the face value of their life insurance policy. The goal of this program is to provide individuals access to discretionary cash that might be locked up in their insurance policy. More information about Fifth Season Financial and their program can be found on our website, fifthseasonfinancial.com. And finally, I just wanted to remind everybody that we have some other upcoming webinars. In July, we're talking about becoming an effective advocate, and in August, we're talking about staying healthy after cancer. So I hope that you'll consider joining us for those webinars as well. Now with that, I'd like to introduce you to our speaker, Dr. Levi. As a dentist with advanced training in dental oncology, Dr. Levi has delivered comprehensive oral care to cancer patients in a warm, supportive, and gentle environment. She received her DMD at the University of Florida College of Dentistry and completed her general practice residency at the New York Presbyterian Weill Cornell Medical Center. She then pursued a fellowship in dental oncology at Memorial Sloan Kettering Cancer Center. So we're very excited to hear more from Dr. Levi, and with that, I will turn it over to her.
Hi, okay, I guess we'll get started. So mainly going to be talking about the oral and dental side effects of cancer therapy. If anyone has questions, they can just send messages, and where you see where it says chat, and I'll just respond to them so that everybody can hear the questions. Okay, so what are we going to be discussing today? So first, I'm going to tell you a little bit more about what dental oncology is, why it's important for patients to visit dentists during their cancer treatment, what your dentist should know about your cancer history, what your oncologist should know about your dental history, some of the side effects of cancer therapy, how to manage them, and when during treatment should you be seeing a dentist and when you should not be. Okay, so dental oncology. Dental oncology is an area of dentistry focused on the managing the oral and dental side effects of chemotherapy, radiation treatment, head and neck surgery, and other cancer drugs. And basically, dental oncologists work within the grand scheme of the oncology team to enhance a patient's life before, during, and after treatment. And so they don't only do dentistry in terms of taking care of your teeth, but they also take care of all the soft tissues. So you might be wondering, well, why is it important to visit the dentist? Shockingly, or maybe not, depending on where you are in your cancer treatment, you may or may not know that there are a lot of oral complications associated with cancer therapy. And actually, poor oral health has been linked to an increased incidence and severity of oral side effects. So as a result, the best way to, help prevent this is to visit a dentist before, to reduce the risk of developing some of these side effects and conditions that may or may not stop your treatment depending on their severity. So to go along with that and what we'll be talking about more in detail, some oral complications include mucositis, which is mouth sores, infections, salivary gland dysfunction, in other words, dry mouth, because your salivary glands are affected by radiation treatment, which I'll go over more later on. Taste dysfunction and alteration, which is more secondary to the dry mouth, and overall just oral pain. And these side effects not only can lead to an increased risk for cavities, but they also can result in dehydration and malnutrition, because if there are obviously problems with your mouth, then you have trouble eating and swallowing, and a whole other slew of conditions, can ensue. Other side effects include trismus, which is limited opening, osteoradionecrosis of the jaw, which is a jaw condition specific to radiation treatment, and osteonecrosis of the jaw, which is a condition specific usually to certain types of medications, and I'll go over more of that later. Okay. So what should your dentist know before you start cancer therapy? Of course, it goes without saying that whether or not you have a history of cancer, you should be telling your dentist all of your underlying medical conditions, because that may affect their treatment, and the type of treatment that the dentist may be providing, it could interact with your medication. So very important that you tell your dentist your whole medical history. Specifically, when it comes to cancer, you want to tell them the type of cancer you have and the stage. If available, your complete blood cell count with differentials, and I'll go over the specifics of that a little bit after. If you haven't started cancer therapy, when will it start? And if you know the treatment, what treatment will you be undergoing? Specifically, if you're having head and neck radiation, where will you be receiving that radiation and when? Any previous therapy, if you've had cancer therapy in the past, and if you have a history of taking or you will be undergoing anti-resorptive medications. In other words, they're colloquially known as bone strengthening drugs, and these include drugs like bisphosphonates, denosumab, bevacizumab, sunitinib. These drugs are often prescribed to patients for multiple myeloma, bone cancers, metastatic cancers to the bone, or even osteoporosis or osteopenia. And then on the flip side, what should your dentist tell your oncologist before you start cancer therapy? Your dentist should obviously tell your oncologist the presence of any sort of dental decay, in other words, cavities, and teeth that may require treatment before cancer therapy is started, any signs of infections in your mouth, and if any teeth need extractions. This is important because you need to allow for adequate healing time. And so if your dentist can tell your oncologist this, then they can coordinate a timeline, and so that you're not rushing in and somehow your treatment is delayed. So the goals of dental treatment before starting cancer therapy, of course, you're not thinking that you're going to do a whole new mouth rehab and you want to make a beautiful smile. Basically, you're going to the dentist to eliminate infection. So if there's anything pending that could halt your therapy later on, you want to get rid of that situation before. So that means eliminating infection through extractions, root canal therapy, and even maybe removing braces, because they can harbor a lot of bacteria. So if you have those, a lot of times it's recommended to remove those. Also, stabilizing any sort of disease that may create any sort of complications during and after therapy. If you're going to be undergoing head and neck radiation therapy, it's possible that mouth guards may be made for you at that visit. A cleaning is recommended before, if your counts are stable and if you haven't started treatment yet. And it's also important to know that we want to allow at least 10 to 14 days of healing when you've done any sort of invasive dental procedures before cancer therapy begins. So you might be wondering, what does that mean, invasive versus non-invasive dental procedures? Here is Dental School 101. If we can summarize dentistry into the two ways: invasive and non-invasive. So basically, the non-invasive stuff procedures are the typical fillings like restorations, root canal therapy, crowns, bridges, removable dentures. Invasive procedures are pretty much anything that's inducing bleeding. So it's extractions, it's gum surgery, and its implants. So the invasive procedures can only be done when your counts are stable, and I'm going to go over that in a little bit afterwards, and or they really should be done before cancer therapy. And the invasive dental procedures is where you need to allow 10 to 14 days of healing. The non-invasive dental procedures, you do not need to allow that healing time. And I think that's important to distinguish, because a lot of people don't realize, oh, what's the difference? Like, do I have to wait a week after getting a filling to start treatment chemotherapy? And the answer is no. You only have to wait a healing time for invasive dental procedures. So basically anything where you're truly going to need to heal. So if you have an open wound in your mouth from an extraction or gum surgery, that counts as invasive. Okay, so the type of cancer treatment we're going to talk about is chemotherapy, stem cell transplants, head and neck radiation, and anti-resorptive medications. And all of these therapies have oral side effects. So chemotherapy, just as a little summary, basically it interferes with the metabolism of tumor cells, their reproduction, and it really, it targets all cells, but it really affects rapidly dividing cells. And since your immune system has a lot of rapidly dividing cells, it affects them as well, and it lowers your normal blood cell counts. So this is important for dental work, as I was saying before, because before undergoing invasive dental procedures, your blood counts need to be stable. So are there certain blood counts that are safe or not safe for dental work? So typically, we obviously would ideally we want all of these counts to be within normal limits, but the most important counts that the dentist is concerned about are your platelets, which are your cells responsible for clotting, and your neutrophils, which are the majority of your white blood cells that are responsible for fighting infection. And so these two, so if you're going to the dentist before you're getting an invasive treatment, these counts are the ones that we want to be stable. So what numbers are important? The basic numbers are, for your absolute neutrophil count, you want your number to be at least 1. For your platelets, you want your number to be at least 50. If either of these are less than their ideal numbers, then for the absolute neutrophil count, it's really recommended that dental treatment is not done if your absolute neutrophil count is below 1, and that's even non-invasive, because this is just a basic defense mechanism in terms of fighting infection. If it's absolutely necessary, then antibiotics can be given prophylactically, but it's definitely not recommended. As for platelets, if it's below 50 and it's absolutely necessary, your dentist and oncologist may speak with you and may consult over potentially giving a transfusion and then going forward with the treatment. But if a transfusion does occur, it's obviously very important to get post-operative blood work to make sure that your counts have actually improved. So now I'm going to talk a little bit more about the specific chemotherapy-related side effects. So these include oral mucositis, infections, taste alterations and dysfunction, dry mouth, neuropathies, dental and skeletal growth and changes and development, but that's mainly in pediatric patients, and I'm not really going to be going over that, and hemorrhage, or in other words, a lot of bleeding due to the low platelet count. So mucositis is colloquially known as mouth sores, and it occurs in 40% of patients that undergo chemotherapy. It's usually seen 2 weeks after high-dose chemotherapy, and it mainly affects the cheeks, the tongue, the floor of the mouth, and the soft palate. It usually resolves when the white blood cell increases, and let's say going to the dentist before and getting a cleaning and making sure that your mouth is in good health may reduce the duration time. It's important to note that, unfortunately, even if you do go to the dentist and your mouth is pristine, you may still get mouth sores. However, I always say it's best to be as prepared as you can be. So you might as well go get your mouth, clean and keep your mouth in good condition, because you're at least giving yourself the best chance of not developing these sores. So like I said before, prophylactic measures cannot be stressed enough. Maintaining good oral hygiene, brushing your teeth twice a day, and flossing, using a mild toothpaste. A lot of there have been studies suggesting that rinsing mouths prophylactically with a mixture of saline and bicarbonate solution may actually help reduce the incidence, but I think that's debatable. I think the bottom line is, just keeping your mouth in good condition, using, and if the symptoms, basically, if you do get mouth sores, what we suggest is avoiding spicy, hot, and acidic foods that may irritate the ulcers. Using a mild toothpaste. A lot of people say that fruit flavored toothpaste or children's toothpaste are actually less uncomfortable than mint flavored, and your dentist can even prescribe to you a fluoridated toothpaste that's very mild. Magic mouthwash, it's kind of a combination that your dentist or oncologist can give to you, but basically it includes viscous lidocaine and Benadryl and a few other substances, and it's kind of just something that you can use to rinse and spit, and it'll coat your mouth before you eat. There's also a variety of mucosal coating agents out on the market, and a lot of these people have found it's helpful. There's no real cure for mucositis. It goes away once the treatment goes away, or stops, in other words, and once your counts improve. So basically, while you have it, you just want to coat the sores, make sure that you don't get an infection. So oral infections are somewhat common, and they usually occur mainly during periods of when your blood cell counts are very low. Bacterial infections occur commonly, but they occur most secondary to mucositis ulcers. So you get the mucositis ulcers, and you don't keep your mouth clean, and then a bacterial infection can result from that. They usually look like canker sores, and they can also be due to drugs. In terms of, there's also a risk of getting fungal infections or viral infections, but viral infections are not they're common unless you're not on antiviral medications. A lot of patients I know, a lot of oncologists will prescribe antiviral medications, so the risk of getting these viral infections is actually low if you're prophylaxed. And in terms of treatment, the control of the infection is related to the patient's prophylaxis. Like I was saying before, if you have a local herpes infection or viral infection, like cold sores, that can be treated with antivirals. Fungal infections are obviously treated with antifungals, and I think the thing to know here is that if you're wearing dentures, it's important to also treat the dentures in an antifungal, because otherwise the mouth will just keep getting reinfected. So apply the antifungal to your mouth, however it's prescribed, and then make sure at night soak the dentures also in an antifungal rinse that your dentist or oncologist will prescribe to you, and make sure that they're soaked, that you're treating the dentures as long as you're getting treated yourself. Another interesting side effect is neurotoxicity. So there's actually some chemotherapies that will result in a phantom tooth pain or throbbing lower jaw pain. Patients may present saying, my tooth really hurts, and it may feel as though one needs a root canal. However, the tooth is actually completely fine. There's no evidence of a cavity there. There's no evidence of infection on an X-ray, and it's really just because these chemotherapies, this is a side effect of them, and they may also result in tingling of your fingers and toes. But for whatever reason, tingling of your fingers and toes when it's in the jaw manifests as a tooth pain. So it's always this. I think this just emphasizes the importance of really telling your dentist when you go in, oh, wait, I'm on chemotherapy, I'm on this drug, so that your dentist can go forward and say, oh, you're on this drug, oh, now I know why your tooth is hurting because of this. I'm not saying that you may not, that's always the answer, but I think it's important, the more information you give to your dentist, the better your dentist can diagnose your condition. So, and especially knowing that a chemotherapeutic agent can cause phantom tooth pain, I think is helpful. Some chemotherapy may also result in dental hypersensitivity, but that usually subsides after discontinuing the therapy. So does the phantom tooth pain. The symptom will usually reside once the treatment is stopped. Okay, so now I'm going to talk a little bit about stem cell transplants. So I've divided up the basically I've divided up the symptoms of stem cell transplants in terms of when the phases are of when you get the transplant. So the first thing I'm going to talk about is before chemotherapy or conditioning. So at this point, you haven't gotten the patient has not gotten the transplant yet, or they have not gotten their high dose chemo before getting a transplant. And at this phase, we just want to eliminate infections, as I was saying before, and patients are at risk for getting oral infections, ulcers, or mouth sores, and any of the conditions that I spoke about earlier. Then chemotherapy starts, and conditioning starts, and at this point the count's lower, and at this point patients are at a risk of getting mucositis at the same time period as I was saying before, around 2 weeks, 7 to 10 days after starting. Also at a risk of getting viral, fungal, and bacterial infections, of getting spontaneous bleeding from the gums, because the platelets, which are the cells responsible for clotting, are lower than that number 50, and so it's very easy for bleeding to occur spontaneously. Dry mouth, which is usually secondary to certain medications. Taste dysfunction, which is usually secondary to dry mouth. And hyperacute graft versus host disease, which I will go over in a little bit. And then the phase 3 of the transplant is when the counts recover. This is about 6 to 12 months after transplant. At this point, the frequency and severity of these acute conditions are resolving because the blood cell counts are recovering. And honestly, the risk of infection is not as, it really just depends on whether or not the patient is on infection prophylaxis. And usually patients are. So usually if your patients are on antifungals, antivirals, antibiotics, and as a result, the risk of infection is lowered. There are still risks, though, of getting graft versus host disease, dry mouth, and of course infections, depending on what medications you're on or are not on. Later on, as your counts are recovering more, the risk of getting infection is obviously diminished, but the risk of getting graft versus host disease is still present. And now I'm just going to talk a little bit more in detail about some of these side effects. So the oral infections are very similar to the infections encountered when undergoing chemotherapy, because before starting a transplant, the conditioning phase is administering high dose chemotherapy. So I'm not really going to spend much time on this, so that we have more time to go over later. But basically, this is just saying, like I was saying before, that bacterial infections may occur. They look just like canker sores, and they're usually secondary to mucositis. Fungal infections can also happen, as well as viral infections, but they're not as common if on antivirals. And the treatment is the same as discussed before. Graft versus host disease, basically this is a condition where the graft attacks the host, and it can be classified as acute or chronic based on what part of the body it affects. So what I will be talking about is chronic, as chronic affects the mouth. The oral cavity is one of the most frequently affected sites of chronic GVHD, and the primary symptom is sensitivity to food, drinks, or oral hygiene products. And this usually happens, it does not happen right after transplant. Well, it could happen within, a year of transplant or after. It can happen earlier, but that's usually less common. Some signs and symptoms include dry mouth, ulcers in the mouth, restrictions of mouth opening, and a sensation of tightness. So it's not only difficult to open, but when you open, it does feel like your mouth, it feels tight in your jaw. It's most commonly seen on the tongue and the cheeks. It rarely will extend to the throat. Sometimes it can be seen also on the lips. And the reason that this is so important is that it needs to be in the mouth. There's only so many things, can only look so many ways. It can be red, it can be white, it can be blue, and that's pretty much about it. So unless it's very clear, a lot of times biopsies are recommended so that this condition can be distinguished from other conditions and so that the appropriate therapy can be administered. There are several medication options for graft-versus-host disease. And the mainstay treatment is first do local treatment and then to do systemic if necessary. I think there's one more thing I just want to say about graft versus host that's important, is that it's a chronic condition, so it never really goes away. And it's really important to visit the dentist frequently if you have this condition, because people with oral graft versus host, there have been some studies saying that they're at an increased risk of getting oral cancer or of the graft versus host lesions turning into cancer. So visiting the dentist frequently and having these oral cancer screenings can help, because then it can be caught early. So oral mucositis, I think we've already discussed this, so I'll move on. And now I'll talk a little bit about radiation therapy to the head and neck. So radiation may result in some irreversible changes to the blood vessels, salivary glands, soft tissues, and bones. The damage of radiation is really localized to where in the body the radiation hits. And it's not only based on the site, but it's also based on the amount of radiation that was delivered, the field size, the fractionation, and the type of radiation. And just one thing that's a little bit different of radiation side effects versus chemo is that some radiation side effects are irreversible, unlike chemotherapy, where most, if not all, of the chemotherapy side effects resolve. So some acute versus chronic complications of radiation therapy. Acute complications include mucositis, infections, salivary gland dysfunction, and taste alterations or dysfunction. The oral mucositis and radiation therapy lasts a lot longer than head and neck, than chemotherapy. So while chemotherapy-related mucositis resolves within 2 weeks of stopping the treatment, mucositis related to radiation therapy takes around 6 to 8 weeks. Some chronic complications of radiation therapy include mucosal fibrosis and atrophy. In other words, the tissues that the radiation affects becomes fibrotic or kind of like tough. Xerostomia, which is dry mouth, which for dentists is really important because xerostomia puts you in an increased risk of getting dental cavities, but I'll go over that a little bit more. Osteoradionecrosis, which I'll also talk about more, taste dysfunction, and infections. So it's important when you're visiting the dentist, no matter at what point you're going, to find out how much radiation was delivered to wherever the radiation was delivered. But a quick way to know if there was a high dose of radiation is loss of facial hair. So if the radiation hit one side of the face and a man is trying to grow a beard, most likely if that area had a high dose of radiation, the beard won't be able to grow in that spot. Also, profound dry mouth and instead, or where the radiation hit, the tissue or the muscle might feel a little bit hard. So trismus is a medical term for limited or reduced jaw opening. It's often seen 3 to 6 months after radiation therapy, and it's due to the radiation, the way the radiation affects the muscles. It makes the muscles contract and become fibrotic. It really, the extent of this limited mouth opening really varies depending on the radiation dosage, the location of the radiation, as well as the patient's medical history and age. Levels in excess of 60 gray radiation dosage measurement are more likely to be associated with this limited mouth opening. And certain cancer treatment are more associated with trismus, but I think it's important to note that it's not so much the cancer as where the radiation dosage goes. So for cancers, nasopharyngeal and oropharyngeal, where the radiation dosage will go strong, in your nose and in the midline of your face, they are commonly associated than one where it would just be hitting, maybe one side of your face. This limited mouth opening can also result from some sort of head and neck surgery, and why it's so relevant to dentists is because it can result in impaired oral hygiene. If someone can't open up their mouth that well, it's very hard to get a toothbrush in there and keep your teeth clean. It's obviously so very difficult to eat, speak, and swallow. Treating it before it even hurts is extremely important. Most times patients will go see a physical therapist and or speech pathologist even before getting radiation treatment to the head and neck. And if for whatever reason that doesn't happen, I would say it's really important to be an advocate for your own health and just ask, hey, I've heard that I might have limited opening from the radiation, or will this affect my limited opening? And if so, what can I do to prevent it now? And basically physical therapy exercises are geared towards maintaining opening. So it's whatever you can do, practice in doing stretches to move your tongue, to keep your mouth open. And there are several from the market. Some include TheraBite and Dynaspan. Here's the picture, but that they just encourage mouth opening and stretching exercises. Another very common side effect of head and neck radiation treatment is dry mouth, or the medical term is xerostomia. And the reason for this is that radiation therapy affects the salivary glands, and basically it zaps the salivary glands if they're in the field of radiation. And this is extremely important to dentists because saliva kind of acts as a natural buffer in the mouth, washing away food and neutralizing any sort of acidity. And it kind of helps. It's kind of your natural protectant against infections and as well as against cavities. So if you don't have saliva, or if you don't have as much saliva, the risk of getting cavities is severely increased. And the doses as low as 25 gray are associated with hyposalivation, and doses higher than that, or higher than 50 to 60, are considered to induce irreversible salivary gland dysfunction. In addition to an increased risk of cavities, it's also associated with taste alterations because saliva actually washes away the taste buds, difficulty swallowing, and speaking. It's important to note, though, that it really just depends, that there are several factors that affect the extent of saliva, of dry mouth that's experienced. And I think it's also important to note that not only is there a feeling of dry mouth, but the consistency of the saliva changes from being more liquidy to a little bit ropier and a little bit more mucousy. And a lot of a symptom of dry mouth also is a burning sensation because, again, natural washing away action. So because of the increased risk of dental decay, frequent dental visits are extremely important, meaning maintaining good oral hygiene to prevent cavities is important. And not sipping on, sugary beverages throughout the day and snacking throughout the day. People often take for granted how much their saliva is helping them until they don't have it. So, before undergoing this sort of treatment, it was okay to just brush twice a day and floss. But then after undergoing this, if you're snacking all day long, the risk of getting cavities will be even higher because you don't have the saliva helping you. So I just got a question: are the extra dental visions generally covered by insurance? Unfortunately, I think it depends on your insurance carrier, but as far as I know, medical insurance will not cover these extra visits. But I think certain dental insurance will, if it's depending on the condition. Either way, at least at the beginning, I recommend going to see the dentist every 3 months instead of every 6, just until you at least get used to the change. And then once that's under control, as long as there's no cavities, as long as your mouth seems to be okay, then you can go back to that 6-month recall. But at least at the beginning, a 3-month recall is really important. So there really is no treatment or no cure for dry mouth, but drinking a lot of water definitely helps throughout the day. There are several salivary gland substitutes on the market. A lot of people find rubbing olive oil on their gums and on their tongue and cheeks actually helps a lot. Sucking on sugar-free lozenges to stimulate the salivary glands, and sleeping with a humidifier. I know that sounds maybe obvious or not obvious, but that I'll say that really helps. And not only sleeping with a humidifier, when you're home, just having a humidifier on. Dry air makes the mouth feel even drier. So just hydrate. And if your dentist does not prescribe to you a prescription strength a fluoridated toothpaste, ask, because there is a prescription strength toothpaste that has more fluoride than the regular toothpaste, and it's recommended to use that at night before bed to also help fight against cavities. So taste ulceration. This is usually secondary to the dry mouth. And a lot of patients say that the first taste bud to go is the sweet one. It's really the extent of the taste and the duration really just depends. It depends on a lot of factors. It depends on the dosage of the radiation, the location of the radiation field, and the salivary flow. Dosages of 60 gray or higher may be associated with permanent taste alterations, but it's also very variable. So I wouldn't. I often tell patients, if you lose your taste, but if your sense of taste, don't get discouraged. It usually comes back, and it usually comes back 6 to 8 weeks after radiation therapy. There are over-the-counter zinc sulfate supplements that some patients say have been helpful. Osteoradionecrosis of the jaw. So this is a condition characterized by abnormal wound healing. I think we don't completely understand why it happens or how it happens. There are several theories out there, but basically, to summarize it, radiation zaps the fine blood vessels that feed the bone, and without those blood vessels to feed the bone kind of acts dead. So if the bone acts dead and you traumatize the bone, then it may not heal properly. People always say like, "Oh, well, why is that relevant?" But you have to think about basic anatomy. Teeth are in bone in your jaw, and so if the bone that the teeth are in is affected, then the overall jaw may not heal properly. This is considered a long-term effect. It usually occurs, if it does occur, much later, about 6 months to a year after treatment. And it's usually as a result of some sort of damage to the tissues overlying the bones. So an extraction, gum surgery, implants. It can occur spontaneously, but it's not very common. It's also just not very common overall. It really doesn't affect that. The prevalence is, I say 5% with almost 5%, but studies it's not really clear because it's hard to really measure when this actually started, and it's also really hard to quantify this condition. It happens more commonly in the lower jaw than the upper jaw, and some symptoms include an area of exposed bone, an ulcer that doesn't heal, chronic pain, numbness, or bad breath. Some risk factors include high doses of radiation, the type of radiation that was delivered, the site of the radiation delivered, and also how often the radiation was delivered. Trauma to the jaw, like I was saying before, so any sort of invasive dental procedures, so those extractions, gum surgery, implants, all of those, any invasive dental procedures can increase one's risk of getting this condition. Tobacco and alcohol usage together, poor oral health, and unfortunately the risk actually increases over time. So there is the best way to manage osteoradionecrosis of the jaw is to try to prevent it from actually happening. That means maintaining excellent oral hygiene, which can't be stressed enough for to prevent any of these conditions. Regular dental recall visits, going to the dentist, going for checkups, going for cleanings. If you keep your teeth in really good condition and don't have cavities, then your teeth will never need to be taken out. And then if you don't need your teeth to come out, then you won't be at risk of an area not healing properly. So prevention is key. Before starting any sort of radiation therapy, any questionable teeth should be taken out before or fixed, restored. So there should either be fillings, root canals, or hopeless teeth should be extracted so that there's no need to do any of this treatment after radiation therapy, so that after radiation therapy, it's just maintenance. Because, like I was saying before, any teeth that are in the field of radiation after radiation therapy should not be extracted. Let's say, though, there's a tooth that needs to come out, or a tooth that's not doing well, and radiation therapy has already happened. I would still recommend not extracting that tooth. There are other ways to treat it, and one way might be to just do a root canal over an extraction, even if it means cutting off a lot of the tooth and just leaving the root in, with the tooth being root canal treated. If one does develop this condition, though, the management is basically wound care, like palliative wound care treatment. So keeping the area extremely clean, conservative measures, and if necessary, antibiotics. The next thing I'm going to talk about is oral side effects not associated with chemotherapy or radiation treatment, but associated with drugs known as anti-resorptive medications. So these are the drugs that I was talking about before, the bisphosphonates, the denosumab, bevacizumab, and sunitinib. Other names for some of these drugs include Boniva, Fosamax, Xgeva, Prolia, Avastin, and Sutent. So, according to the American Society of Bone and Mineral Research, osteonecrosis of the jaw is an area of exposed bone in the head and neck area that has been present for over 8 weeks in a patient with no history of radiation to the jaw. In other words, it's a non-healing, it's abnormal it's an abnormal healing wound that's been present for a long time in the jaw, but there's been no history of radiation. It actually looks very similar, and the presentation is very similar to what I was just talking about before, osteoradionecrosis of the jaw. The only difference is that it's associated with these drugs rather than being associated with radiation treatment. And the risk factors are also similar. It's usually preceded by dental surgery. It can occur spontaneously, but that's not that common. Most of the time, it's associated with some sort of invasive dental treatment. And basically, without going over the detailed pharmacology of these drugs, but the drugs kind of alter the normal functioning of bone cells, and if bone cells don't function normally, then they can't also heal properly. So it's also recommended, just like with osteoradionecrosis of the jaw, that if you have a history of taking these types of drugs, extractions, not that any sort of extractions, gum surgery, or implants not be performed, because there's a risk of this abnormal wound healing. And again, prevention is key to not developing this. Of course, unfortunately, it can occur spontaneously, just like osteoradionecrosis can, but it usually does not. And so maintaining good oral hygiene, going to the dentist frequently, keeping your mouth in pristine condition, will make it so that you don't need to get a dental extraction. If you don't need a dental extraction or gum surgery or an implant, then the likelihood of getting this condition is severely diminished. Again, if you're going to be getting this sort of treatment, any teeth should be extracted 14 to 21 days before starting any of these therapies to allow for adequate healing. And even after stopping these treatments, it's important that teeth are still not extracted, because the drugs stay in the body for a very long period of time. So even after a few years, the drug is actually still in the body, and so there's still a risk of developing this. So oral and dental management during cancer therapy as a summary. If I haven't emphasized this enough yet, I can't emphasize enough that routine oral hygiene is essential for minimizing the severity and incidence of oral side effects. Brushing your teeth twice a day, flossing once a day, as you've been told by your dentist, extremely important. Depending on the type of cancer treatment you will be getting, you may be experiencing dry mouth, or you may be at risk of experiencing dry mouth, and as a result, your dentist may consider prescribing a fluoridated toothpaste to kind of help fight against cavities. Like I was saying before, a lot of patients find the non-mint flavored toothpastes are much more tolerated, and they don't burn as much as the mint flavored one, so that's something to consider. Avoiding any sort of alcoholic mouth rinses, as those burn, and using an extra soft toothbrush. In addition to using an extra soft toothbrush, if your counts are low and you have mouth sores, you can make the toothbrush even softer by rinsing it in hot water, and if you do that every 15 to 30 seconds and as you keep brushing, the toothbrush will be even softer. So what about dentures and orthodontic appliances, or any sort of removal appliances? If you've recently had a transplant, minimize wearing dentures for the first 3 months, because they are a huge forest for bacteria. Soaking them in an antimicrobial rinse when not being worn is important. Of course, you should never be sleeping with your dentures, especially when undergoing therapy, but you never should be. And avoid wearing any sort of removable appliances when mucositis or any sort of mouth sores are present. As I was saying before, braces may be removed before starting high-dose chemotherapy or conditioning, as braces are a huge harbor for bacteria. After therapy, visiting the dentist is extremely important again. After receiving head and neck radiation therapy, no extractions are recommended in the field of high dose radiation. And it's key that in the field of high dose radiation, because you have to, it's not that every single tooth can't be extracted. It's just the teeth that were in the dose of that were in the field of the high dose radiation. So if a tooth potentially needs to be extracted, before going forward with it, it's important to say, wait, hold up, tell your dentist that, I've had a history of head and neck radiation therapy, and I don't know if I can get this tooth extracted. And then your dentist will most likely, or should, call your oncologist, your radiation oncologist, find out where the radiation was delivered and how much, and then the appropriate treatment can be rendered. Also, using a prescription strength fluoridated toothpaste every night is very important to help prevent against cavities. And like I was saying before, any of those anti-resorptive medications, if you have a history of taking them, no extractions should be performed thereafter. And that's it. Does anyone have any questions? Okay, so I just got a question. How long after treatment ends do patients need to be getting specialized dental care? I think that really varies. I would say always, but I'm a little biased. It's definitely dependent on the oral condition. If your mouth wasn't really that affected by cancer therapy, then go see a dental oncologist, after therapy, and dental oncologists will probably give you the okay, and you can go back to your regular dentist. If, however, you're experiencing several side effects, then it may be better to stay with dental oncologist for longer, depending on what your side effects are. Where can patients find dentists who specialize in dental oncology? There aren't that many dentists that perform dental oncology. I guess the best way to look for one would be to look at your local hospitals and look for cancer centers and see if they have programs. If those local hospitals had dental oncology programs, then they most likely produced, they will be a great research for you. So I'm based in New York, and I did my training at Sloan Kettering, and Sloan Kettering always, it has a fellowship program, so you could always call up their dental department to ask them, and a lot of the fellows are throughout the U.S., and that's a good research. I know also MD Anderson has a dental oncology program, so if you're in Texas or somewhere on the West Coast, that might be a good resource as well.
Well, thank you so much, Lauren. That was
okay. Well, I guess if nobody has any more questions, I hope my lecture was helpful, and thank you for everybody that attended.
Thank you so much, Lauren. That was absolutely fantastic. For those who are attending, please feel free to complete the survey that you'll be redirected to. For those of you on the phone, I'll be sending a follow-up email with a link to the survey as well. So thanks so much for joining us, and have a great rest of the day.